be LACID and sponsored by the Early Career Immunologist Committee. I'm Monica Lawrence from the University of Virginia. I'm going to be moderating our first case, which is going to be presented by Shan Chandrakasan from the Emory University, with his mentor being Jack Bleesing. So without any further ado, we'll get started with our first case.
Thank you, Monica. Can I have the next slide? So the case for today came to us at a month age. She's a young girl infant. Primary presenting symptoms at 1 month of age was poor weight gain and chronic cough, and was empirically treated with azithromycin with partial response. But she really did not get well, but by 2 months she had other symptoms that started coming in, and the main symptoms were she presented with watery diarrhea, but on evaluation had a Pseudomonas blood culture that was positive multiple times, so had a Pseudomonas sepsis, and that's complicated by ascites, acute liver failure. And at that time, when they did inflammatory markers, her ferritin was in 2000, so there was transiently consideration for HLH. But with aggressive treatment of Pseudomonas sepsis, the hyperinflammation settled. Her liver enzymes took a while to come back to baseline, but it was still significantly elevated. So as I said, the episode responded well to antimicrobial therapy. Subsequently, because of persistent watery diarrhea, she had an extensive evaluation of GI, and she remained inpatient for 3 months for poor weight gain and continuing loose stools. So in terms of GI workup for persistent loose stools, she had a scope done. The scope showed the inflammatory component of it was minimal. She had some inflammation in the gastric, duodenal, and colonic mucosa, but the main striking finding is marked increase in apoptosis, both on the duodenal and colonic crypts. And another striking finding was absence of any plasma cells in the biopsy. So for these findings, because there was still some inflammation and she was having failure to thrive on significant loose stools, she was started on a modest dose of 1 milligram per kg of prednisone. Within a couple of weeks of starting the steroid, she came back with another acute presentation. Again, she had Pseudomonas sepsis, but within 2 weeks of that resolution, she had worsening of respiratory symptoms, needing ICU care and respiratory failure and intubation. During this admission, she had a BAL done, and that showed pneumocystis, and for which she was treated. Again, this time around, she responded to treatment for pneumocystis, and her respiratory symptoms improved. So by then, the combination of twice Pseudomonas sepsis, GI inflammation with profound apoptosis on the GI biopsy, and also the pneumocystis as an immune deficiency defining illness made us think something significant. So in terms of her brief family history, she was the firstborn in the family, non-consanguineous marriage. So there was no history of any significant immune deficiency in the family. Both parents are otherwise perfectly healthy. And a physical exam, the only striking features were she was proportionately small. Her head circumference, length, and weight all were significantly less than third centile. So,
okay, so before Shan goes further into the immune labs, which I know everyone's eager to see, does anyone have questions for him about the history, the physical exam, anything that he's covered so far?
Shan, was it, how long was
the
she,
chat box.
Sorry. How long was she treated with systemic corticosteroids?
So in total, it was for 2 months, but it started out with 1 milligram per kg, but it was progressively decreased to 0.5. And even on, our concern was even at 0.5, she had pneumocystis. So we are concerned at that point. This is a very mild to moderate dose. At that, she got pneumocystis. The concern for looking for immune deficiency.
Okay, so Shan, there's a question from the chat box about are the lymph nodes palpable or any hepatosplenomegaly?
No lymph nodes, no hepatosplenomegaly. The liver was just palpable, but in terms of ultrasound, it was normal size.
Okay.
Was she malnourished, severely malnourished, a little bit malnourished?
She had, by around 3 months, she had significant failure to thrive. All her height, weight, and was less than third centile. So yeah, she had significant failure to thrive.
Okay, so questions. Everyone wants to know about the hair. So Yesen is channeling Sergio. She wants you to look at the hair and then the skin and bone and teeth. And Joyce also is worrying about the face, and so is another Sharat. Everyone wants to know.
Okay, so in terms of hair, we thought it was a little bit thin, but otherwise there is no obvious finding. Again, she didn't have a lot of hair when she was an infant. So in terms of faces, she did look like the pinched faces are like a little bit bird-like. Maybe I'm imagining things, but that was the only finding. But again, she was proportionately small with small head. Like head was not the only microcephaly, like she was proportionately small. And any other, there was no nail abnormalities. Again, she wasn't having a teeth, like we are still seeing her as a 6-month-old, right? She didn't have any dentations by then to know whether there were any teeth anomalies or not.
Okay, so Ben already has a guess of TTC7 and ligase 4 is coming up, but we'll get to the differential once we see the labs, which Roni wants to see. So let's go forward with the labs.
So in terms of immune evaluation, again, we can the immune workup showed absent IgA and really low IgM, and IgG was also low. In terms of TB&K, what we initially noted was she was profoundly lymphopenic with CD4 counts of 400, CD3 counts of 400, but both CD4 and CD8 was decreased, but the decrease was more profound on the CD4. As you can see here, the CD4 was 155 and the CD4-CD8 ratio is 0.67. The B cells were essentially normal, though at one instance we had a low B cell number, but on multiple other instances we had normal B cell and NK cell profile. The interesting part of it is over time, in another 6-month period, the CD4-CD8 ratios progressively decreased to 0.1. The same happened on the lymphocyte compartment. The absolute CD3s dropped from 400 to 45. And when we looked at naive and memory compartments and recent thymic immigrants, when we initially did the evaluation at 3 months of age, she had, even though the absolute lymphocyte count and also the CD3 counts were low, there was still a good majority recent thymic immigrants and good fraction of naive CD4 cells. 85% was CD45RA positive. But by the time she was 12 months of age, the percentage of naive progressively decreased to 16%, along with drop in CD4 counts. We did proliferative mitogen and also CD3-based proliferation assay. Both showed a decrease in CD3 and PHA-based proliferation assay with increased background apoptosis. This was done in my clinic. So we could see CD45 fraction CD3. And when we checked for TCR V-beta repertoire, there is absent representation in 9 V-beta clones and also oligomer distribution of another 10 V-beta families. So with this, do you want to stop here and ask for more information, or?
Well, Jack wants to, he doesn't trust your flow, so Jack wants to know, did the newborn screen show anything?
So this particular, again, in Georgia, the newborn screen started in August 2016, so this baby was born prior to the TREX assay that we had. Baby was born prior to our newborn screen being active.
Okay.
And
okay, anybody? Okay. Anybody else wanting any more labs before Shan moves forward?
Shan, is there evidence of protein losing enteropathy? Is where the T cells going? Are they being pooped out, or what do you think is the mechanism?
Like, again, I don't know why there was this progressive lymphopenia. The GI inflammation of her stool calcification has been modestly elevated, like 500 to 800 in that range. The one other thing is she was started on a modest dose of steroids. Again, these are not like more than 2 milligram per kg. Most of it is 1 milligram or lesser than that. We were worried about, because even on the proliferative assays there was increasing apoptosis. So we even considered chromosomal breakage, or again, as we discuss differential, we can discuss those differential, why there is progressive lymphopenia. But we didn't see like a massive protein losing enteropathy. Her albumin on steroids held okay. Stool also on antitrypsin. Again, I don't remember off my head. I think if it was sent, it was within normal limits.
Right. So I think there's some really good questions being asked.
I'm sorry?
Yeah. So Yesim wants the telomeres, which I know you have coming. So before we get to that, we have a question about B cells. Are there any other than the immunoglobulins and the total B cell number? Did you do B cell phenotyping?
So we didn't have a B cell panel to look for class switch B, but what is evident is in multiple tissues there are no plasma cells. So obviously, though there are B cells, they were not progressing towards a complete maturation. So I'm pretty sure if you did a B cell class switch assay, we would have hardly any class switch B cells. So and in terms of titers, I think we started immunoglobulin way early, even before she had any set of vaccinations to check for.
Okay. And there's a request for imaging and looking especially at the cerebellum on MRI of the brain. I think you have that coming.
So
yeah,
can Ronnie tell us what he's thinking about?
Yeah, that would be a great question. So why cerebellum, and will anyone need an eye evaluation for this patient?
But specifically, it's a connection with DKC that I think is a really good question, as you'll see in the next slide. But not every DKC patient obviously has cerebellar hypoplasia. I think that's what he looks for.
Uh-huh. And I think many of the, in that spectrum, apart from DKC, even chromosomal breakage disorders can give hypoplastic cerebellum, right? Can I move to the next slide?
Yeah, let's go on.
So the other evaluations that we did for this patient, again, the bone marrow, in fact, was hypercellular. If you look at the CBC, the cytopenia was not very striking. The platelets were 94. Hemoglobin was 8.5. And the neutrophils, in fact, were very robust. This is 8,800 neutrophils. And again, the lymphopenia is marked. What is also impressive is in the absence of any active sepsis, persistently we could pick up premature forms in the peripheral blood, both in forms of nucleated and metamyelocytes and band forms. So when we did the marrow, what was another finding, apart from there is hypercellular and normal child lineage MS boxes. There was no evidence of myelodysplasia. But there was mild to moderate reticulum fibrosis. We thought the peripheral metamyelocytes nucleated reds could be a manifestation of ongoing fibrosis in the bone marrow. The bronchoalveolar lavage showed hemosiderin-laden macrophages. This is a repeat lavage after the diagnosis and treatment of PCP. The liver biopsy showed, again, by then she was on TPN for a long time. So there was both canalicular and ductal cholestasis with biliary proliferation. There is increased iron staining and portal inflammation with bridging fibrosis, stage 3 or 4. CT scan showed multifocal patchy consolidations, but in addition, there was chronic lung changes, both in the intestine and the parenchyma. And MRI showed basically deep white matter volume loss with secondary ventriculomegaly and delayed myelination. There was no cerebellum normal. Just looking at the labs here, when the liver enzymes were AST was in 300, ALT was in 140, bilirubin 1.2, alkaline phosphatase 600. This liver enzymes were done when she was having active diarrhea, so the albumin was also low. So just to summarize, we have a 14-month-old girl infant with failure to thrive, 2 episodes of pseudomonal sepsis, 1 episode of pneumocystis, and progressive T-cell lymphopenia with CD4 depletion more than CD8 with a normal B and NK profile, progressive loss of naive T-cells, and decreased proliferative response. Bone marrow and liver fibrosis with chronic lung changes, GI inflammation, minimal inflammation with increased apoptosis, and peripheral blood showing cytopenia and also leukoerythroblastic type of finding with some platelets and hemoglobin being low, but A and C within normal limits. So, is there any other?
Okay, so the differential the group has thrown out so far is TTC7A, DNA ligase 4, and DKC. Is there anybody else wanting to make a guess at what this might be?
Why don't we, perhaps we can think about a immunologic scenario before we start sort of shouting out individual genes, because I'm not convinced yet that we have adequately explained what is in fact an immune deficiency, what is primary, what is secondary, what is the most interesting pathology that this child, is it the liver, is it the GI tract, is it both? So I think it's easy just to throw out genes, but maybe somebody can tell me how they view the deficiency. Is this combined immune deficiency? What is this?
Okay.
I think with time, it was more apparent this was combined immune deficiency. But when we initially started out, the profile was not that marked. But again, as it's not only the lymphocyte numbers being low, it's we are having progressive loss in the naive compartment. Again, I don't know if this kid also has a thymic stromal issue, as we are seeing fibrosis in many places. Our other concern is there an additional thymic stromal defect causing progressive loss of naive and also CD4 T cell output being decreased. So those could be.
Then do you think that it all started okay and that this is all, rapid senescence or rapid loss of cells?
So I just think that there is a component of rapid senescence. I don't know whether it's because of a primary metabolic disorder within the T cell or a telomere biology or a DNA repair defect. So the differentials in that could be broad. Again, each time we did a proliferative assay, we could see a lot of background apoptosis. Again, with stimulation, we are seeing a huge apoptotic fragment. So while this kid has gone through multiple infections and stress, I don't know whether the lymphocyte compartment was stressed and became senescent in some form. So again, those are great questions, but we don't have any specific answers on that.
Did the GI biopsy show any lymphectasia? And has she had only one?
No evidence of lymphangectasia.
All right. Keep going.
So, because we have multiple what seem unrelated but also related in a way when you think about other disorders that can lead to some form of progressive fibrosis of the liver, with or without bone marrow, and overall constitutionally small, failing to thrive with some GI inflammation showing predominantly apoptosis. We thought, as we're thinking about senescence of T cells and overall senescence, we thought checking telomere length would be something we need to rule out. So when we did initial telomeres, again, the way it's commercially done here, we have either a 2-cell panel or a 6-cell panel. The 2-cell panel just gives you total in the lymphocyte compartment, total in the granulocytes. We had that come back as significantly lower than first centile. But since we are dealing with a senescent, like what we thought is rapidly aging immune compartment, we thought it will be important to know what is it on the B cells that doesn't seem to be affected, and NK cells, so that we will know whether it's purely a telomere biology problem versus some form of a proliferative attrition of telomere length. So we repeated it with a 6-cell panel that looks at, apart from granulocytes, we have a little bit more granularity into CD45RA, so those would be naive T cells, and CD20 and NK cells. So even when we did a 6-cell panel, the telomere length was short across the board. So that made us very concerned about the telomere biology defect. So we did a DKC panel, which was done through Cincinnati Children's, and that was negative. Then we went to a whole exome, and that clinical whole exome through Emory University, that came back negative. We did a del dupe and a CGH area, that also was not contributory. So by then we thought there was also reports of short telomeres in conditions with DNA repair defect, most commonly DNA ligase 4, and certain chromosomal instability disorder can also give short telomeres. So we didn't have a clinical lab doing radiation like fibroblast radiation sensitivity. We sent it to Dr. Gatti, but it was never done. So in the absence of a cellular study for radiation sensitivity, we relied on flow cytometry markers to look at a DNA damage response. So Roshni Abraham from Mayo Clinic was kind enough to do those tests, and what we found was pretty normal gamma H2AX response to radiation, phospho-ATM, and phospho-SMC1 staining pattern. So at least those were not screeningly abnormal. So that is the closest we could do to understand some radiation sensitivity. And that's all we have. Like the telomeres are low, there is a progressive immune attrition, there is progressive fibrosis and failure to thrive with what looks like an apoptotic enteropathy. We don't have a specific diagnosis, but we think in the realm of telomere biology problems, the diagnosis yet to be made.
John, do you think it's possible that you have a new disorder and the telomere length abnormalities are just happen to be part of it? You know, for example, cardiac hyperplasia, which is study published.
We reached out to Dr. Armanios in Johns Hopkins She's interested in doing a whole genome in this patient to try to understand. And we have fibroblast on this patient, although it's not viability of it is not that great, but we have it frozen somewhere in our genetics lab. So it's possible. Again, the possibility of did you mean cartilage hair hypoplasia?
Yeah, there are now telomere defects found in those patients as well. So I'm just curious. Maybe
cartilage hair hypoplasia.
Somebody mentioned TTC7. Maybe telomere lengths are abnormal in a variety of disorders, and so that sort of brings back the question of how would you classify this disorder? Is this a primary immunodeficiency disorder? I'm still not entirely convinced. Or is this a DKC variant, or is this a telomeropathy that we just haven't characterized yet?
Yeah.
Do you have more slides? Let's see the. Maybe we should see the last slide. Yes.
So again, the differential of DHH, DNA ligase, all of them, though they are not primary telomere biology disorders, they lead to short telomeres. We know, like when you look at telomeres, again, at least when I look at it, I make sure is it a telomere that is short across the board, especially in the naive T cells and B cell compartment, because we can see on T cell compartment if there is disorders leading to T cell immune senescence. We do see on the T cells alone, because of proliferative immune senescence, you can see not from a telomere biology perspective, but from just proliferative attrition, you can see a relatively short telomeres in those patients, but that doesn't count as a telomere biology disorder. But I do worry if it is across the board, especially even more so on the CD45RA naive T cells and also in B cells if it is low. Either a primary or a secondary problem eventually affecting the telomere complex, leading to short telomeres is what I start worrying. But again, I'd like to know what others think.
Should have you been able to improve her GI system? Can you document that this can be made to respond to immunosuppressive therapy or other therapy? I think it's very important before you would consider it.
Though I put up several management questions, unfortunately, this kid from having purely watery stools started having like bloody stools. And in fact, we lost this patient from a massive GI bleed at home. And even before the child could reach a facility, the child suffered a cardiac arrest. So, though I put up management questions more for discussion standpoint, but she had a partial response to steroids, and we are always worried trying to push steroids in the face of such profound immune deficiency, right? So, in terms of differential, I put in TTC7A in addition to, again, there are other disorders, TTC7A, TTC37 all come under that spectrum where there can be an stromal defect and also GI and combined.
And it affects the liver, it affects the thymus, it affects.
Yeah.
So that to me seems still the very high on the differential, also because of sort of the course of her disease and how this all ended. And with DKC patients and enteropathy, when you put them on immune suppressive therapy, tacrolimus or things like that, things get better. And if you take care of infections, and Sharat asked about viruses, things tend to get better, and so you sort of prove what the underlying mechanism is. And I'm not sure that was achieved in this case.
Yeah, what
I'm not sure that the telomere. I'm just wondering if the telomere, if that's just another. Sorry.
No, like the inflammation.
Shan, I think we have just a couple more minutes for us to wrap up, but I do want to get to this question that I think is really important for those of us who may not see telomere disorders as often. Can you address Mark's question about the normal phenotype of the immune phenotyping in telomere disorders? How would we recognize a telomere disorder in clinic?
I think in terms of the DKC, the classical ones, they have more subtle immune deficiency. It's the one that presents in infancy, the more like, I don't know how to even spell it out, Hoyle-Henderson syndrome. When they present, they typically tend to have more combined immune deficiency with more enteropathy. The immune profile, many of them have more profound B-cell problems than T-cell. T-cell, we can have a subtle to very significant CD4-CD8 ratio reversal and features of, again, I saw a couple of papers that talks about CD4-CD8 ratio reversal in DKC patients. And also, there are subtypes of, within the DKC, the RTL1 has much more profound B-cell issues. And in general, most DKC have the B-cell compartment somehow seem to be affected along with T. It's not like the T minus B plus is not the classical phenotype. I think most of them have significantly low B, subtle to very significant T-cell abnormalities, combined immune deficiencies. But the important thing to remember is they can present with more an immune phenotype as an infant, more a bone marrow failure phenotype as a 5 or 10-year-old. So, and the immune phenotype when they present with bone marrow failure in a 5 or 10-year-old is slightly more subtle when compared to when they present as immune deficiency as an infant. They may or may not have bone marrow failure underlying. So, more than a specific immune defect, if we have a kid who is constitutionally small, having unexplained enteropathy with variable immune deficiency, with more apoptosis and some reticulate pigmentation, that's when you can do an eye evaluation, MRI, and then think about sending telomere length.
Perfect. Okay, thank you so much, Shan and Jack. I know we have a lot more to discuss about this case, but we've got to probably move on to the next one because I know we have a great case lined up second.
Sounds good.
Thank you so much.
Okay, can everyone hear me?
Yes.
Great.
Yep.
Okay, this is Andy Snow from Uniformed Services University of Bethesda. I'll be moderating the second case, which is going to be presented by Dr. Marylin Desjardins, who's an assistant professor in the Department of Pediatrics at McGill University Health Center, and we're joined by Dr. Helen Su as our senior mentor. She's the chief of the Human Immunological Diseases section at NIAID at the NIH. So I will let Marylin take it away.
Okay, so thank you. Good evening. So I'm happy to share with you this interesting case. So this patient was around 18 months old when he was referred to our immunology clinic. It's a boy, and he was referred for evaluation of atopic dermatitis and recurrent infection. The family was living around 2-3 hours drive from our center, and the patient was referred by the infectious disease physicians over there. So in terms of his past medical history, so he was born at 41 weeks gestational age. It was the first child of the couple. He was delivered through a C-section because of failure to progress, and he was breastfed until 7 months of age. His neonatal period was relatively normal, with only mild jaundice that didn't require any treatment, and his umbilical cord fell off when he was 1 week old. In terms of his infection history, so he had his first infection when he was 5 months of age. It was a balanitis that was treated with oral antibiotics. And it seems that this infection recurred when he was 8 months and then at 13 months of age. At 6 months of age, he had a chest X-ray documented the pneumonia, which was also treated with oral antibiotics. Then at 12 months, he had acute otitis media, again treated with the oral antibiotics, and these infections resolved rapidly. Then at 14 months, he was admitted to the hospital for febrile neutropenia. He was diagnosed with pneumonia and treated with IV antibiotics. The neutropenia resolved upon treatment, and it was after that infection that the infectious disease physician decided to refer the patient to the immunology clinic for further investigation. In terms of his other medical problems that occur around this age or maybe in a few months after his initial evaluation, so he had symptoms of atopic dermatitis that started around the age of 2-3 months. He had one episode of impetigo that resolved following treatment with topical antibiotic cream. He was assessed by a dermatologist that confirmed a diagnosis of pustular psoriasis. And in the few months after, he also suffered from recurrent molluscum contagiosum that was treated with curettage. Also, he suffered from cow's milk protein allergy that presented with vomiting or mucousy bloody stools. He was put on a avoidance diet. In fact, the mother who was breastfeeding was on the avoidance diet, and when this was resolved, he was put on the hypoallergenic formula. And then this evolved to an IV-mediated milk allergy that was confirmed after he had an episode of lip swelling when he was exposed to milk protein into a cookie, and then he had a positive allergy skin testing for milk. In terms of medication vaccination, so he was initially on tacrolimus topical ointment, but that was switched to topical steroids after the assessment by the dermatologist. And when we saw him in the clinic, his vaccination was up to date, and he already received one course of the live attenuated vaccine, the MMR and the VZV vaccine, but he didn't have any complication from the vaccination. And in terms of his physical exam, the growth was normal. He had no obvious dysmorphisms. The tonsils were present, and there was no palpable lymphadenopathy or splenomegaly. And over the skin, he had some dry lichenified areas with some erythematous patches over the ends and the fingers. In terms of the laboratory results, what was striking was that this patient had a high white blood cell count of 24 times 10 to the 9 per liter cells, and that was attributed to increased lymphocyte count, while he had normal neutrophils, monocytes, and eosinophils, and he didn't have any abnormalities in the other cell lines. On the smear, there was reactive atypical lymphocytes. So because here there was a concern about possible leukemia, the patient had an abdominal ultrasound which showed a mild splenomegaly. So at this point, our team decided that it was important to rule out the malignancy, so he was referred to Immunology for a bone marrow assessment. This was performed, and this evaluation came back negative. And what was very particular about this case was the family history. So when we asked about the family history, we discovered that the father was investigated as a child for splenomegaly, molluscum contagiosum, as well as a high total B cells. But there was no clear diagnosis about this. And then both parents were not related, were both of Caucasian origin. And in terms of the familial history on the father's side, the grandmother suffered from Hodgkin lymphoma, and the great-grandmother, who was still alive, also suffered from recurrent warts, had shingles, recurrent sinusitis, as well as hypertension.
So let's, hey Marylin, let's stop there before you go into the labs and just get some thoughts from the audience just based on the history. So it sounds like we have, you know, your first patient had some atopic dermatitis, more frequent infections, lymphocytosis, and what appears to be, a family history that with some hints in there about, common infections. If anyone in the audience has some thoughts, I've got one question regarding the platelet size. Was there anything unusual there in his CBC?
So, no, the platelet size were normal.
Okay. Any other thoughts from the audience at this point? I realize we don't have a lot of information yet. Got one guess at Doc 8.
Just because I'm the other person doesn't Doc 8.
Right. Okay. So we can rule out Doc 8. A couple other ideas. CARD11, that's an interesting one, and just a hyper IgE of some sort. Had you screened for any genes normally associated with hyper IgE? I mean, we talked about Doc 8, but STAT3 or anything?
So the IgE level from the peripheral blood, we'll see the result in a minute, but it was normal. It was not really increased.
Okay. Well, let's go ahead and move on to the labs in the interest of time. Some folks are asking about T cell subsets, but let's go ahead and move to the labs.
Okay. So we did a TNB cell enumeration to see which cell subsets were responsible for the increased lymphocyte count. And to our surprise, in our patient, it was the CD19 positive B cells that were increased. He had some relative decrease in the count and percentage of the CD3, CD4, as well as CD8, with a slight increase in the CD4-CD8 ratio. And the NK cells were normal. And because of this interesting story about the father was referred to our adult immunology clinic, and we had some assessment on his side. And for the father as well, we observed that the CD19 B cells were increased, while he had normal count in terms of the T cells and NK cells. And when we did the extended phenotype for the B cell subpopulation, we realized that the more immature form of B cells, so the IgM positive as well as the CD5 positive B cells were increased for both the patient and his father, while the CD27 and the class switch B cells were decreased. And we again confirmed that the IgH rearrangement pattern was polyclonal for both of them. In terms of the immunoglobulin levels and serology, so our patient had mild hypogammaglobulinemia and mild decrease in IgA serum level, absent IgM, and relatively normal IgE. He had normal response in terms of specific antibody to tetanus and diphtheria, while he had no response to Haemophilus influenzae type B, despite the fact that he was revaccinated with a conjugated vaccine. And he had no response in terms of the strep pneumoniae specific serotype, despite vaccination with Prevnar and as well as Pneumovax when he was 2 years old. So the father on his side had a mild decrease in serum IgM levels. He had normal response to the protein conjugated vaccine and had a decreased response to the polysaccharide with only 11 out of 23 serotypes that were above 1.3. And in terms of the lymphocyte proliferation assay, so our patient had mild decrease response to pokeweed mitogen stimulation as opposed to the reference control, while both the patient and the father had normal response to PHA, CONA, and CD3. And before maybe we just summarize the relevant findings for the patient, I wanted to give a little bit of story about the father. So when he was 2 years old in 1987, he was diagnosed with splenomegaly lymphocytosis with large percentage being B cells. And he also suffered from extensive molluscum contagiosum that was treated by a dermatologist and resolved maybe when he was around 4 years of age. Then he had onychomycosis that is still persistent today. And when he was at the physical exam, he had one wart on a finger. At 11 years old, he had chickenpox and then shingles in 2013. And more recently, he had a knee effusion that was positive for Staph aureus. He was treated with IV antibiotics. And that effusion recurred in 2013 and 15. And that these episodes were treated empirically. So to summarize the findings, so this is a 2-year-old boy with a familial history of polyclonal B-cell lymphocytosis and splenomegaly. He had decreased immunoglobulin levels as well as specific antibody response to Haemophilus influenzae type B and to polysaccharide antigens such as strep pneumo. And we thought that this patient had some associated T-cell defect in regards of the molluscum contagiosum, as well as the decreased proliferative response that we observed to the pokeweed mitogen. So because of these findings, at the time, the immunology team decided to start the patient on immunoglobulin replacement therapy, and we started to scratch our head to find a differential diagnosis.
Well, all right, so before the big reveal, I guess, we've had a few excellent guesses in terms of a differential. A few folks have guessed a STAT1 gain of function. We had one CD40 ligand, although I think the IgG was normal in Dad. Are there any other thoughts? Had you checked those at that point?
So at that point, there was no specific gene testing that was done for the CD40 ligands. I mean, there was the IgM was more decreased in both, and there was the other one were not in the DAB were normal in terms of the levels so far.
Got it. Okay, and so I guess
our impression
I guess we can
more. Yeah.
Go ahead, Marylin. Sorry.
So our impression was more like we're searching more for kind of a combined immune defect because of the finding in both the B and the T cells, but
right, and I think the thing that stands out is the B cell lymphocytosis with the preponderance of naive B cells and lower memory B cells, which I suppose leads us into the next phase. So maybe we can trudge ahead.
So in fact, at this point, we decided to perform a literature search, and we tried to find a diagnosis that would unify all these findings together. And the possibility that we came with was suspicion of a CARD11 defect beta disease. Beta that stands for B-cell expansion with NF-kappa B and T-cell allergy. And with this possibility in mind, we initiated a collaboration with Dr. Snow to see if it was possible to assess if the family has this genetic disease in fact.
So I can take it from here. This so full disclosure, I know this case well, and in partnering with Marylin and Bruce Mazer at McGill, we sequenced the patients and indeed found a rather unusual mutation in the CARD11 gene, which included an in-frame 4-amino acid deletion as well as a missense mutation at H234L. I apologize, this cartoon looks a little strange on my computer, but there's a schematic it's supposed to be there of CARD11. This is the 5th mutation we've described in the gene. And the differential here in terms of benta is the splenomegaly and polyclonal B-cell lymphocytosis with a preponderance of naive and immature cells and low memory and class switch B cells. The serum antibodies are sort of variable. Sometimes IgM is low, but often can be sort of on the low end of normal range, especially for IgG. The reason they come in the clinic most often and first are the frequent sinus and ear infections, as Marylin described in the first patient, and we often see poor responses to specific vaccines, particularly the pneumococcal polysaccharide vaccines. So just to move ahead, we went ahead and tested the mutation for gain-of-function activity, and indeed on the bottom here you can see we transfected our T-cell line that does not express CARD11. It does have a reporter for NF-kappa B activity. We know CARD11 turns on NF-kappa B. And we tested all variations of this mutant because it actually took a while to confirm exactly what it was. But if you focus on the red line, basically when you express this protein in T cells, you get activation of NF-kappa B independent of T-cell receptor activation, a little like the first gain-of-function mutation we described, E134G. So that really confirmed it was a gain-of-function CARD11 mutation, as some of you in the audience guessed. And let's see, we do have a question from Jack about T-cell hyporesponsiveness as a primary or secondary consequence. That's a great question. We think it's primary, but to be honest, we don't know too much yet about the T-cell defect. We know if we express this protein in primary T-cells, it does lead to a level of hyporesponsiveness. So we think it's direct, but that's something we're looking into. So I want to leave plenty of time for the sort of clinical management piece. Oh, just to reiterate on the next slide here. So so CARD11 is a scaffolding protein expressed specifically in B and T cells, and it's required for NF-kappa B activation through the antigen receptor. So basically, normally it gets phosphorylated after antigen is recognized, and that allows the formation of this so-called CBM complex. When the gain-of-function mutation's on board, basically this complex forms spontaneously without requiring antigen receptor engagement, and that leads to constitutive NF-kappa B activity. And oddly enough, in this germline encoded mutation, we get a specific, basically B-cell lymphocytosis with a hypo-responsive effect in the T cells. So with that, I'll let Marylin finish on sort of the clinical management of these patients, and perhaps we can have Dr. Su chime in as well, as we've seen these patients and others at NIH.
Okay, so in terms of the patient, so there was a question about if we need to continue the immunoglobulin replacement therapy for the patient. He's currently on sub-Q replacement and is doing well with very few viral upper respiratory tract infections and some gastroenteritis. But one of the issues is the infusions are becoming more and more difficult because there's a lot of apprehension about them, despite the fact that we're using topical anesthetic. And it seems that many patients with this defect were in fact treated with vaccination booster with conjugated vaccine, where their response is waning. So that was one of our questions. The other thing is it's becoming more and more difficult to manage the molluscum contagiosum. So he has them on his abdomen, on the back, and the perianal areas, the legs, and also the area where he has the pustular psoriasis. And they're progressing. And now he requires sedation in the OR for the curettage by the dermatologist. And finally, maybe one of our other questions was how frequent we should do the surveillance for lymphoproliferative disease in this patient, at which frequency, because somatic mutations are also described in B-cell malignancy. So this patient had a CT scan that was performed in August 2015. That was relatively normal. The spleen is to borderline a limit for the age. And we perform EDG PCR as well as TMG every 6 months. So I don't know if there's any suggestion or comments about these issues or anything else you'd like to bring up.
So perhaps we could have Dr. Su chime in, because she's seen quite a few of these patients. Helen, would you have any recommendations regarding, IVIG, or excuse me, sub-QIG and, treatment management of the molluscum?
Okay, just to give some background, we follow a cohort of about 10 of these patients at the NIH. And if you look at the very early description in JXMed from Andy Snow's group, you can see that the initial presentation was very ALPS-like with lymphoproliferation. Not much autoimmunity, at least in the initial patients, but that was the first three from the first family, and then there was a P4, which was more evocative of these particular cases with more problems with T cell functions. So overall in our cohort, I think now that we've been seeing more and more patients, I think it's clear that you can have some of them with a more of a combined immunodeficiency flavor, more problems with recurrent infections, not just bacterial, but viruses like recurrent shingles, BK virus we've seen, and warts, et cetera, in this family. And then there's a few that just happen to have lymphoma pop up in 20s or 30s. But in terms of malignancies, we've only had maybe three. This one grandmother, the initial first family with a CLL, and then we just saw another family which the maternal grandfather likely had a mutation. He had lymphoma and died of it in his 20s. So that ends up being maybe like 30% of the cohort of some sort of malignancy. So it's definitely an issue that we are concerned about, especially since the association with the somatic mutations in gain of function, CARD11 and B-cell lymphomas. But then I just want to also point out, we've also more recently gotten some patients that look completely healthy. I mean, very little increased lymphocyte numbers, and maybe that they're adults and it's gone down. Really, they look pretty healthy. So I think the spectrum is quite broader than what we initially described, and that leads us to maybe tailor the therapy a little bit more. So previously, many of the patients really didn't need IVIG. You could just, their antibody responses weren't really durable, but you just could just re-immunize them and keep them boosted, and they did pretty fine. But this particular patient, and I think another one, probably should be on IVIG, but they're still having problems too. So that also brings up the issue of at what point will transplantation be an issue. I don't think anyone's going out and transplanting them now, but we are concerned about several of them.
What about we have a question. Yeah, we have a question about EBV, which I think might be relevant to the next slide. But any thoughts about the molluscum? I know we've seen several patients that have similar issues dealing with the molluscum. Do you have any advice for Marylin about
how to treat? Well, I mean, I think many of them have tried cantharidin and imiquimod and everything, right? And I think the first family benefited from a sort of a topical cidofovir mixture that helped that. But in general, this has not been as big an issue as in, for example, the DOC8 patients. I think it's not gotten as bad, and so we haven't really done anything more than what people usually try topically. So
okay,
I have no great
let's
for that.
Well, I know we're getting close to the end of the hour. We've got some great questions, but maybe we'll have Marylin jump to the next slide, which I think is really the final one to address the EBV issue, because that's an important one.
Yes. So for the father, so we also were concerned about regarding possible evolution to a lymphoproliferative disorders. So in August 2015, he had the CT scan, which showed a mildly enlarged axillary lymph node. For example, on the left side, there was one that was 1.7 centimeter by 1.2, and he has also the top normal range spleen size at 13.3 centimeter. And this was associated with permanent SDG activity on the PET in these slightly enlarged lymph node, as well as in the non-enlarged inguinal lymph node. And the father EBV PCR is positive with serological evidence of past infection with the EBV VCA IgG that positive. And you have the trend over time of the EBV PCR, which seems to be stable. So we were currently observing the patient, repeating the EBV PCR and planning on controlling the imaging, but we were wondering if we should be more aggressive about this and maybe go to a biopsy or other recommendation for this.
I think.
Helen, do you have any thoughts on that?
Yeah. In general, I take the principle that we've applied to all of our other patients who have EBV susceptibility, not the ones that result in HLH, but with high EBV requires monitoring if there's a huge increase. I think the threshold for investigating if there, concurrent possibility of lymphoma needs to be low, which would include PET scan where it's appropriate, CT scan, et cetera. But I don't think what we usually do is trying to use anything like rituximab just over concerns of driving EBV into other subtypes and no way to monitoring them if you can't keep the B cells there. So it's basically watchful waiting and low threshold for intervening and looking for malignancy.
Again, we've had a few patients now with chronic EBV. Is that correct, or sort of high EBV viral loads? So this can be a common feature. Is that fair to say?
I mean, this is not typical. We've only had a few patients who've been EBV positive that we've been able to detect EBV. The level that we see in this particular patient, 85,000, that's actually the level that I would see in many of the DOC8 patients, for instance. We don't. Okay. I mean, I think the X-Men patients that we do follow with the EBV susceptibility, they tend to have much higher by 1 log. It's up right by tenfold factor, and then I think we're a little bit more concerned about them. They seem to have more potential for developing lymphoma. But this, we just watch.
Okay. Well, I think I know we're just past the hour, so we should probably wrap things up. I just want to thank Marylin and Shan for presenting 2 terrific cases, and Jack Bleesing and Helen Su for joining us as senior mentors. Just to remind everyone that if you have interesting cases, whether they might look like these or might be something educational and different, please send them to us. We're always looking for new and interesting ones. I know we have at least one more webinar scheduled this spring, next month, but we're always looking for more cases, so please send them along. And again, thanks to USIDNet and LACID for their generous sponsorship, and thanks to all of you for attending this webinar.
Thank you.
Have a great night.
Thanks.